Mhm.
All right. I hope you all had a good quick break. And we're going to focus now our conversation on reassessment and trying to figure out what the point of it all is. All right. So we're going to talk about what the goals are. Again, we're going to link reassessment to the CANs and find ways to help make sure reassessment is working for you. So before we get started, I wanted to share with you what I've heard about the buzz on reassessment in Idaho. And then I will ask you, and you can do this now, to share your thoughts, feelings, reflections about reassessment as I do this. So one of the things I heard is that I've been told a reassessment has been done, but neither I nor my child knew it happened. The one thing I heard. Another thing I heard is we receive multiple services and I can't keep track whose reassessment is happening when. Why can't there just be one? Good question. Someone other than my child's therapist does the reassessment, which is confusing. I can't tell the difference between an assessment and a reassessment. Hopefully that's not because the person is just doing another assessment, and finally, the last thing I've heard is I've seen my child re-traumatized by having to tell their story over and over again, which is something that was mentioned early on in our previous session. So let me pause and see if there are any reflections, thoughts, feelings that folks have around reassessment that they would like to share via the chat.
So we have a comment. After a few years of all of this, I have learned to navigate it better. And now I ask to work with one person. So that comes from being a veteran in the system.
Good.
Another comment that agrees with every statement that you put on your slide. And somebody saying this is where the secondary trauma comes in over and over and over
again.
Multiple kids, multiple times, right?
Yes, absolutely. So to that person who just said that, when I was first asked to talk about reassessment, I kind of panicked because to me, reassessment takes 5 minutes. And I was like, what am I going to say? Like, reassessment means updating things on the CANs that need to be updated. It takes 5 minutes. What am I going to say? Right? Because we definitely do not want people telling their story over and over again for no good reason, right?
And Dr. Fernando, we have a comment that somebody shared with us from the parent network, and it says that a provider, they've been told by a provider, I can't use somebody else's assessment. I'm ethically required to do my own. That's where we have misinformation flowing among providers.
Absolutely. Absolutely. That is a very rigid interpretation of the requirement. So I can take an assessment that's done by anyone in Idaho, right? If someone were to see me, I could say, hey, I would like all the information you have on your client to share with me, particularly if they have another CANs or your assessment information. And I will take that and I will say to, let's say Ruth brought herself and her child, and I'd say, Ruth, I got the information from Joe therapist, and is this correct? And she'll say, yep, that's correct. I said, is there anything new I need to understand? And we'll update the assessment from there. I don't have to hear the trauma story in order to make a determination of what's happening. I can trust that the trauma story, if Ruth tells me that trauma story is correct, okay, great. No one has to talk about it. I can read about it.
So we have a parent asking, please tell me, where is it written that they do not have to do their own assessment? Because clearly this is happening so often that parents really want to be able to offer their provider the formal knowledge that
it's not that they don't have to do their own assessment. It's how they're interpreting what their own assessment means, right? Like I do have to do my own assessment, but the description I gave you was I took someone else's information right? Verified it with the family and then asked updates and then used that for my assessment. I didn't force the family to go through a 0 to 100, tell me the story all over again process, right? I might also talk to Joe therapist to say, hey, thanks for sending me that stuff. I met with the family. Here's what I talked to them about. Do you have anything to add? Right? So we can update each other on what's going on. I don't have to traumatize the family a second time to tell me the story so that I can work with them. So it's the interpretation of what doing your assessment means. That's where some therapists are getting very rigid about it. And I'll tell you why. Now, mind you, I'm telling you this because I used to run a Medicaid clinic myself. Okay. We're paid to do assessments. And we set up business models where we assume that when we get a new client, we're going to do X number of billable units for assessment. So there's, and I'm not saying that the therapist is like trying to scam anyone. I'm saying that's how our system is set up, right? There's an incentive to put you through an assessment. So we have to help clinicians fight that incentive to do the right thing and not re-traumatize clients. I might get fired from Idaho for saying that, but it's the truth.
We'll defend you.
Other thoughts or comments about reassessment?
Comment on reassessment. Oh, just disappeared, but I will get it back. Reassessments are good, but it would be nice to be asked as a parent if anything has changed.
Yeah, absolutely. Right. It is your story after all. All right. I'll let you all keep mulling that over and send them over, and I'll ask Ruth periodically if there's any new things. I'm going to keep moving us forward because we have a shorter time this session. Right. So what is reassessment all about? Right. Reassessment is orienting ourselves to change. And when I talk about ourselves, I'm now talking about the treatment team. Your treatment team, if you're in level 1, could be yourself and your therapist, right? I mean, your child, their therapist, and you. If you're in level 2, there's a child and family team. If you're in level 3, there's a wraparound team, right? So ourselves is any of those combinations of people. And what we're trying to do is orient ourselves to what's happening, what change is happening. So one of the things we want to make sure we do is we're maintaining a shared vision, a shared understanding of what's happening. So it provides us an opportunity to check in on what's going on. And in addition, it provides us an opportunity to make sure that everybody who's part of our team is informed about what's going on, right? So it's nice, as someone just said, it's nice to have a reassessment because it's a pause. Let's take a pause. Let's check in, right? Let's make sure everyone understands what's happening. We're still on the right path. We're still okay with the plan. Okay. Now, what's hard about reassessment is when you've got multiple services, multiple providers, multiple plans, multiple different reassessment schedules, right? Dr. Israel talked about the 120 days and all of that. That's great if you're having one service, right? Every time you add a service, you're adding a new timeline for 120 days. Or even a different timeline that's not 120 days. So tracking all of that can be really difficult. So the person who said, I have one person who does this, hey, talk to them because they figured out how to get coordinated care, right? Because that's the issue is, as a provider, I can understand why I have my timeline. I need to be reminded that your child has multiple timelines going, and we need to make it as easy as possible for the care to be coordinated and so that you all don't go crazy trying to do all these reassessments. Okay. another thing around orienting ourselves to change is that this is about updating the story, updating your story, right? We expect change to happen because of the impact of the interventions that your child's participating in. That's what's supposed to happen, right? Change can also happen because the circumstances of our lives change, right? Life circumstances can enhance the impact of our interventions, right? A family member, for example, might decide to participate, right? Or a life circumstance change in your family can distract from care, right? Someone gets sick, for example, in the family. Or the life change could even redirect the plan, right? A wildfire burns down the house of the family. Guess what? We've got to change the plan now because there's other things that need to be addressed, right? All of these things have to be taken account when we're updating the story, right? That change happens because, it's not about one therapy session to the next. It's about everything that happens in and around all those sessions that causes change to happen for a young person and their family. So we need to update that story. And then, as we talked about previously, make sure everyone else is updated on that story. And finally, we need to make sure we're right-sizing the plan. Okay, Dr. Israel gave some lovely examples on how to use the structure of the treatment pyramid as a strategy to make sure the plan is still the right one. Okay, and I just mentioned about what happens when our story changes, right? We may need to update the plan as our goals might change. We might even need to change the plan of an intervention if it isn't working and identify a new intervention to take its place or new support. We might need to change the plan if we realize the CANS isn't accurate and therefore the level of care recommendation isn't appropriate because it's not helpful, right? On a happier note, we might need to right-size the plan because some of the things that we were working toward, we've achieved. And we need to celebrate that and move forward in the plan, right? So there's a lot of reasons why we want to right-size the plan because we're orienting ourselves to change. One thing I forgot to mention in, let me go backwards, in updating our story, right? It's in the note here, but I didn't say it. I want to say it out loud. When we're revisiting the story, the goal is to talk about how your child's story is changing. It's not about revisiting the story of the trauma to tell it over again. It's about how the story has changed. And that's the focus of the reassessment. Okay, so it's not a rehashing, it's an updating of the story. All right. So what does reassessment look like? I have to tell you that every time you meet with a professional, a reassessment is happening, or it should be happening, right? That's how we stay focused on the plan that we've set forth. Dr. Israel talked about different types of therapy situations and what might happen, right? I think he talked about one type of situation where it's, the therapist might say to you, so what are we working on today, right? That's not helpful, as he mentioned, right? A reassessment happens every time you meet with someone because they're trying to understand, what happened between the last time you were here and today? Did something shift? Did it not shift? Because we're always trying to assess whether what we're doing is helpful, right? So that mini reassessment happens every time. So feel free to participate in it, right? Feel free to participate in it. And provide the therapist an update or provide a team an update. Okay. I know that in wraparound that happens very formally. They'll check in on it, right? It may not be as formal in a therapy situation, an individual therapy situation, but you can prompt it, right? Say, here's what happened since the last time we saw you, right? I mentioned that the reassessment is a formal temperature check, right? Because we want to make sure that the plan is still working. Okay, it requires all of us to talk to each other as providers. We cannot get away from that. In fact, that's as a person who used to run a mental health agency, right? We build that into the time of our clinicians so that they have time, that it's an expectation we set for them, that they collaborate with other providers they're working on cases with, because they need that time to make sure care is coordinated. And by the way, you can ask for a reassessment whenever you want as a parent, right? If you don't feel like it's working, you can ask for a reassessment. Let's look at the cans. Let's look this over. This doesn't seem to be working. I just want to check in on something. Whatever you need to say, you can ask for a reassessment, even if it's before the 120 days or whatever, right? You can say, hey, so-and-so's dog just died all of a sudden, or in my case, I had a cat that was stolen. That really messed me up for a minute there, right? Those are times to ask for reassessments. If there's something that happens that throws your child off kilter, it might be time to reassess just to make sure that the plan is adapting itself to what's going on with your child at the moment. Okay, let me pause and see if there are any thoughts, questions, reflections.
I think you just answered the question. So should a child disclose something that the cans, should a child disclose something, the cans should be updated to show the new level for treatment, correct?
Yep.
Okay. And then
Yep.
we're getting a couple of comments, just that most therapists we meet with do not take the time to read assessments that are given to them. They want the whole story each time.
Yeah.
How frustrating it is when they haven't read what they've been given ahead of time.
Yeah, that's really an old school way of training people. That's how I was trained as a psychologist, that and this is not in our ethical guidelines, so it has nothing to do with the real ethics, right? But I was trained that unless I did a full assessment, it didn't happen. That doesn't work in our world today, right? And if you will recall, therapy was first created for, individual people who don't have multiple complex issues, right? In our world where our children have multiple complex issues and you have to get different types of supports at the same time, that model just does not work, and it's not trauma informed, right? Idaho is a trauma informed touting system. So the more feedback you give them on this has re-traumatized my child, has re-traumatized me, this is not trauma informed, the more they'll get the message that they need to continue to work on having a trauma informed system that doesn't provide incentives for traumatizing people inadvertently. Okay, I'm not saying they're doing it on purpose. I think it's an inadvertent consequence of the way that the system is structured. All right. So let's talk about what one can do in reassessment, and I'll just orient us to this theory of change. So we talked about this theory of change in our last session, where when we complete an assessment, right, it helps us know what's going on right now and what's happening. We develop that shared understanding together with the team, right, which means we have to communicate, talk, come to consensus, etc., on where we could, the young person could benefit from support, your child could benefit from support. We then develop goals that represent change, right? And we're going to identify what change would look like and how we need to address it. So it's not just a goal, it's the steps to get to the goal. And then we have to identify the interventions and make sure that we're accessing strengths as well as building strengths at the same time, right? This is part of the treatment process. So earlier I focused on the first two components. Let's focus on the second two components. Okay. So in a reassessment, we want to make sure that the plan is working. Let's look at the goals that are supposed to represent a change. And for those of us that work in a transformational collaborative outcomes management perspective, we want to help your child and your family transform, right? It's about transforming your lives so that your lives are better. So let's go big or go home, right? So the goals should represent transformational change, significant change, right? You don't want your child just not to be angry and depressed. You want them to have friends, get along with others, get along with you, and be happy, right? Transform their lives. Let's not just be less depressed, right? And we need to identify those action steps and how we're going to do that. I want to highlight something Dr. Israel said yesterday about strengths and bring it home to Idaho. So we've done some work, our team has done some work to understand what is helping kids in Idaho get better. Okay, so the strength building in Idaho is for real. We have identified through our research on the data in Idaho that there are 6 strengths in particular that when they are developed have result in overall better outcomes for children. And this includes your children if they are currently have a CANS in the system, that they were part of us looking at this process, right? And here are the 6 specific strengths. The first 3 are internalizing strengths, and the last 3 are externalizing strengths, or externalizing assets, internalizing assets, right? Coping and savoring, that ability of your child to be able to be in the moment and enjoy the moment. That is such a pleasure, right? When you have an anxious, distractible, dysregulated child, to have them be able to just sit and enjoy the moment is like, it's amazing, right? I know what that's like. My child was one of those children. Having interpersonal skills, the ability to make and maintain friendships and relationships. Resilience, the ability to know that you have strengths that you can tap into that can help you, right? That's what resilience in the CANS is all about. It's not the ability to survive. It's the ability to have strengths, know you have them, and tap into them. Educational setting, having school be a place where you can find strength and support, having peers who influence you in a positive way that make your life better and that support your growth and development, and having your family as a place you go to for support. They're there for you, they understand you, and you rely on them. That's family as strengths. So these are the 6 strengths that we have found in Idaho on your CANS that have show a correlation with the most reduction in needs. And you say, well, what is the correlation? What does that mean? So let me show you a little bit of data. So this little graph shows in last year, in 2020, each quarter. And I'm showing you the quarters just so you see that there's, this wasn't just one time we looked at it. We actually looked at this for several years. I'm just showing you last year's data. The bars on the left, the tall bars, show percentage of needs resolved when 4 out of the 6 strengths on the left were developed. Let me say that again. So these bars right here represent the percent of needs resolved. So these are percentages. So you can see this is a little bit over 60. This is almost like 67, right? Like these are high 60s. 60% of needs resolved when 4 out of 6 of these strengths were developed. Okay. Over here, we have strengths that weren't developed. So there are strengths to develop. They weren't developed. We still have some needs resolved, but around the 30 to 40%. Okay. When the 4 out of 6 of these needs were not developed, here's the amount of improvement. There's still improvement, but look how dramatic the improvement was in needs resolved when we developed 4 out of 6 strengths. Okay. Now, is it just that we developed the strengths? Probably not. The stories we're starting to hear about cases or families where 4 out of 5 of these strengths were developed talk about engagement, right? The family's improved engagement in the process when the focus was also on developing strengths, right? So we can continue to address needs by focusing on need reduction, but we can enhance, right? Even multiply that impact if we develop strengths at the same time. And there's data in Idaho that shows us that this is true. So let me pause here and see if there are any questions. Hope I explained that okay. Okay, if there are none, let me move on. I only have a few more slides left, so hopefully it'll give us some time for discussion. So yesterday, Dr. Israel talked about checking in. And he walked you through how to check in on the treatment pyramid. I want to drill deeper into the treatment period and talk to you about how you can check in using the CANs. Okay, so let's take that the top of the treatment pyramid, the goals, right? Because it was level of care on one side, diagnosis on the other side, strengths in the middle, and at the very top of the pyramid is goals. So let's talk about that. All right, so what can we do to check in? So this is a story of Jason, who's very depressed and angry. He's made a suicide attempt, a serious suicide attempt in the past, like they had to do life-saving measures to save him. And he's currently contemplating suicide. So how do you check in as a parent if this Jason is your son and this is his goal? So the first thing we want to talk about using Dr. Israel's structure of the treatment period is the long-term goal, right? That's the top of the list that he provides you. Is suicide watch, which represents suicide, right? This is where Jason feels like giving up. He's got suicidal thoughts. Is this still our goal, right? This is depicted as red, meaning it's a 3. Is this still our goal? If this is still our goal, right? If Jason is still feeling like he's might hurt himself, then this is still our goal. If Jason is not there anymore, guess what? We might be done with this goal and we need to talk about that. Okay, so let's check in on the long-term goal. There are usually short-term goals that we have to address to get to that long-term goal. So what is underneath Jason's suicidal ideation, right? He's depressed and he's angry. His depression showing up as sad, he's withdrawn, he's disengaged from friends, from family. He's angry, he argues, he fights physically sometimes with people. He's destructive, he destroys things, he punches holes in the wall. He doesn't know what to do with his anger. Okay, these things we feel like if we were to address them would help him not be suicidal, right? Here's the long-term goal, here's the short-term goals. Okay, long and short is relative, right? Because you don't want your kid suicidal for very long. So this could be like something we're working on for a month. What are the interventions and supports? So we're checking in on the long-term goal. We're checking in on the short-term goals, right? These are orange because they're rated 2 on the CANs. Here are the intervention supports. Individual therapy, is that working? Is it helping address the depression? And we identified some strengths to build, right? We realized that the 6 strengths in Idaho that showed the most impact on reducing needs were things that would be applicable for Jason in this situation, right? So we want to build back strengths in family, that Jason's not withdrawing from family, but working, looking to family for support. Is that helping? What are the things that were put in place to help build that strength? And interpersonal, Jason's withdrawn from his friends. What can we do to help him be able to reach out, even though he feels weird and he feels like no one likes him and he's been such a jerk to his friends? I don't know how to re-engage, right? What have we done to help him build that strength back up to address his depression? Okay, maybe we had Jason go to group therapy to address his anger, right? Like to realize that other kids get angry too, they struggle too. What are some things that we can do to connect him with other kids, but also help him, right? And how can we, let's say Jason had a great relationship with teachers at school and was very engaged in school before all this. How can we re-engage him? So let's check in on long-term goals, short-term goals, interventions, and supports. And at every step, let's figure out during this reassessment, if everything's still working, if we need to change anything. Let me stop and see if there are any questions or reflections on this. I have another example like this.
Here's one that just popped in. Can those short-term goals be my son's long-term goals?
Yes, they can.
Okay.
Absolutely. Right.
Yes.
Now you notice here the long-term goal has to do with safety. Right. So we have to deal with that first. Now we might be able to reduce the suicidal thoughts for Jason, but still need to work on his depression. Right. So then depression might be the long-term goal, and we might be addressing something else as a short-term goal. So these things can move and change. That's why that theory of change is really important.
Okay, that's very helpful. I'm just going to add the further comment from same parent. For interventions and supports, we just have OT. He goes to school, so he gets time away. Music therapy, these are not enough. And what she's referring to is that he is at home destroying property, yelling at parents, body checking parents. So the ultimate question being asked is this something that I have to put together as a parent? I mean, is it like, does this help exist, or is this something I have to figure out?
I think help exists, and the way that you can continue to prod for more help is to use the actionable items on the cans to show how intense the needs are for your child, right? Like, look at how anger control is rated if you have the cans. If you don't ask, how is anger control being rated for my child? And where else, right, is it showing up on his cans? Because I don't feel like this plan reflects the story of what's happening to my child. It's a great example to sort of walk through this.
Mm-hmm. So we also have a question, who does this planning? When is this addressed? Is this part of the wraparound process?
This is part of the wraparound process. This particular type of plan might be done by the mental health person addressing mental health issues as part of the larger plan of care in wraparound, because, you know, wraparound can cover many areas. This is more typically a mental health kind of perspective. The other one I'm showing you will be similar, more developmental, but this one's mental health. So if you have a therapist, they should be doing this. The care coordination, the care plan can also reflect some of this, but maybe not as detailed. And you should be part of this, coming up with these, especially the interventions and supports. That's why we ask what's worked before and what hasn't, because it might give us a clue as to what might work now, right? I was talking to a colleague last night who lives in New York, who's a psychologist also. And she said, one of the things that telehealth has opened up that we're trying to solve, because, you know, I'm licensed in certain states. I can't work as a psychologist in Idaho because I'm not licensed in Idaho. And that's an equity issue for telehealth, because if I have particular expertise, right, in working with, let's say, Filipinas, because I'm Filipina, and there's someone in Idaho who can't find a Filipino therapist to work with, they should be able to work with me, right? So this is an issue, right? If you have a child who has a specific need and there's no one else, they should be able to find that need and get that need paid, get that support paid for, so that things can continue to move forward. And telehealth is opening some of those doors. Other questions? Let me give you another example that's slightly different, okay? But is the same kind of structure to help you go through, how do I check in on whether or not the plan is working for my child? So this is Alex. He's a 10-year-old, has a diagnosis on the autism spectrum, and becomes agitated when his parents take away his favorite toy as a way to set limits. Now, there's nothing we're going to do to change autism spectrum. It's not going to go away, right? Remember when I talked about addressing the what versus the why? This is the what. We know what autism spectrum is. What we're doing here is helping Alex maintain functioning and improve his functioning, not changing the autism spectrum disorder, because we can't. So the way it's showing up is his emotional and physical regulation, right? That's the agitation. The question is this still our goal, right? The short-term goals have more to do with maintaining Alex, which is about helping the parents. So helping the parents with their understanding of what's happening, what Alex's autism spectrum looks like over time, and how to help him as he grows and changes, right? Because as kids get bigger and more mobile, and their emotions start to change, kids on the spectrum, they need different ways for us to work with them as parents. So the intervention here is to support Alex's parents around what's going on with Alex, who's on the spectrum at this age, and maybe build their strengths around their social resources for support that they have, right? They don't have. Because, you know, one of the things that helps parents the most when they have kids with neurocognitive disorders, or just kids that are tough, right, is to have some relief, like to have a moment to collect yourself, have a moment to relax, have a moment. So having social resources is critical for parents, all parents, right? Another area is a short-term goal is helping caregivers with discipline. Now, the discipline part is part of the supervision item in the CANS. So the CANS item called caregiver supervision is a blend of monitoring and discipline or setting limits. So in this case, we're looking at the supervision item for setting limits or discipline, right? Again, we might need to provide some parent coaching on helping them actually implement some of the strategies that they're learning through parent education. And the strength to tap into here is they're very involved in his care and always have been. Okay. So again, this is about supporting the caregivers, supporting Alex's parents, not saying there's something wrong with them. It's just Alex is growing and changing, and the way we need to work with him has to grow and change with him as well. So let me stop there and see if there are any thoughts or reflections.
Okay, we have been madly answering some questions. I still have a question or so to answer, but there are sort of Idaho-based things that
Okay.
the Federation, and please, folks, please continue to call or email us with questions about specific services in Idaho and how you access them and are they available, et cetera. I'm going to go back and make sure I don't see one that I
Okay.
haven't passed on to you. I will say that there was an earlier comment, and it reminded me of how we ended the last session, that while not related to exactly where you are right now,
Sure.
people are frustrated with the disconnect between then the schools and they have these cans and they're learning about their child, but the school is not really learning about the child. And kind of we don't have a lot of trauma-informed schools in Idaho, not truly trauma-informed schools at all.
Yeah.
So people are asking, how do we bring the school into being a helpful partner in their children's?
Yeah. That's a really good question. And it's hard to have all the child serving systems that impact your child work together and be on the same page all at the same time. So for example, Idaho foster care doesn't necessarily use the cans, right? So there's another system that's not quite engaged or speaking the same language. So oftentimes, you have to continue to keep advocating. I did the same thing. Now, my child's neurocognitive diagnoses were on the high functioning side. But I really didn't like some of the tools they were using with my son. So I gave them a CANS that my son and I completed and told the psychiatrist, right? I said, because he needed some medication, I said, here, why don't you use this? I'll tell you how it works and you can continue to put your perspective in here because it might be helpful, because it's something my son understands and can work with you on it. And so I also had to educate his student study team, which is the team is the first step in the state we were living. That's the first step towards an IEP. I had to educate them on the CANS and how to use it because, again, my son was comfortable with it and he was able to talk about things using the CANS when he couldn't just talk about it in his everyday language. It structured the way he was able to talk about things. So that you might have to bring the CANS in and advocate for it and help them understand, hey, here's what's going on, here's why. And if you can find supports from other parents or even your therapist, that might be a way to also help, because I did that a lot as a therapist myself.
And I will add that tomorrow is an important session for those of you struggling with these issues, because we do a bit of a dive into advocacy tomorrow. And we'll have parents with us to sort of share some of their successes in advocacy and recognize that this is a challenging world. We do have another question. Are there further trainings for mental health providers after the initial about how to complete the CANS assessment? Training to use the CANS for treatment planning and ongoing strengths-based treatment?
Yes. So the children's mental health trainers from Idaho are offering something they call CANS in practice. That's a treatment planning training where they will go over how to develop plans and using strengths in those plans with the CANS. So that's one. There is another training that's probably a few months out. That's for supervisors, so that supervisors can get additional training in how to support their clinicians in using the CANS. So that's not yet out there in for Idaho, but will be soon. So there are those trainings. Also, if you're a CANS user, you had to get certified on tcomtraining.com. There is a free course that you could take called Action Planning, which goes through, it's an asynchronous independent study. You don't have to take a test, training that walks you through action planning with the CANS. So there's different ways to get some support that are available to you as a provider right now. And by the way, parents, if you want to get more training on the CANS, we are happy, the Parade Foundation is happy to give you free access to our training site. so you can see how our clinicians get trained and certified. You could do it if you want. Just let me know. I'm happy to help in that regard. All right, I've got one slide left. I want to just go over it really quickly and then we can stop. So I just want to remind you of what the strategies are to get some help to help you with reassessment, right? So checking in on the cans means checking in on the items that are embedded in the plan, and then checking in on other actionable items, right? It's not starting the cans from scratch. That's not a reassessment. That's an assessment. Okay. So if you've got this feeling like they're going through the whole thing, say, whoa, wait a minute. Here are the things that I think we need to talk about. Here's what you need to update. Here's why. Okay. Updating the story, right? Again, is about talking about all these things that have changed, right? And it's really important that the focus is updating the story, not retelling the story. And finally, push for that one coordinated CANS for your child, right? Tell them, I'll sign a release. I know that I heard a story from a children's mental health clinician of how they coached a parent to push for the new therapist to get information from the other therapist and refused to put their child through another assessment because they need that one CANS, one child, because this child was not doing well with having to tell their story all over again. So again, checking in is only on those things that need to be updated. That story is your story. Make sure you guide the discussion on what needs to be discussed in a reassessment, and make sure that your providers are sharing and coordinating with each other. And with that, I will say thank you. That's the end of my presentation.